Welcome to Chapter 27, Hygiene and Personal Care. I know in the CNA training they teach you how to do this, and so we're going to go through this chapter hopefully pretty quickly. There are lots of slides in here on the skills, so know that we're just going to briefly go through those. If you even touch on them, you may just look at them. Practice of providing hygiene and personal care. You need to be aware of the personal habits of your patient. If they prefer to do all their care first thing in the morning, or if they prefer to do it at night, that's fine, just whatever it needs to get done. Patients in the hospital think, well, I haven't been up and doing a whole bunch of stuff, so why do I need to get cleaned up? Their bodies sweat, medicines smell, all those things happen, and it's important that they do have a bed bath every single day or do personal care every single day that they are in the facility. It is just the way that we can prevent any infection from getting into them in any source at all. Please be respectful of their cultural beliefs and of the age of the person and all of that goes involved with personal hygiene and care. And I know that they probably touch on that in CNA school, so I'm not going to dwell on that. One thing that we do as nurses while we are doing the hygiene and personal care of our patients is we assess them a little bit closer. We can assess their skin a little closer. We can talk with them more independently and more intimately during a bed bath type situation, because you're not focused on anything else, you're focused on that. During the patient care, you can communicate with the patient as to what you see on their skin, maybe give suggestions on some dry skin if you see that. Maybe there's a mole or something that you notice, ask them if they've noticed it, watch it for progression, just different things like that can be brought up during this time of care. Bathing cleanses the skin, it removes organisms that can cause infection and odor, provides comfort, and continues to promote the patient's health and overall well-being. And I don't know about you, but having a really nice, clean self just makes you feel better. And even if you feel like, if you don't feel well in a hospital, that can just be the only thing that really makes you feel good, even though you can't get up and move around. Sometimes just that will help you have a better outlook on things. So assisting with patients' hygiene, again, you guys have already been trained in this, so I'm not going to beat this a lot. Just remember that you always try to include every aspect of their body when you're cleaning them. Let them do as much as they possibly can. But if it is a total bed bath, then make sure that you do a total bed bath. And that means peri area, even if you did just change their attends, clean it again. Foot care, shaving if they need to be shaved, all of that's part of it. So offer it. If the patient refuses, that's fine. Document they refuse. While performing your hygiene care, you need to make sure that you observe the skin. Make sure that you watch to see how it is appearing, if it's dry, if it looks cracked, if it's got open sores, if it looks moist, if it looks swollen, if it looks tight and shiny. All of that is part of your assessment. Healthy skin, hair, nails, and mucous membranes contribute to the overall health and well-being of your patient. The nurse will have the opportunity to assess all of these during the bath time. Skin is the body's vulnerable barrier to the outside world, yet it is strong, self-renewing, and easily cleaned. Mucous membranes of the lips, nostril, anus, urethra, and vagina area all join seamlessly with the skin. Sweat glands are an accessory organ of the skin and produce a water-like substance. These glands are activated by heat, nervousness, or stress. Sweat can produce a foul-smelling body odor. During bed bath care, the nurse cleanses all areas of the skin system in an effort to maintain healthy tissue, reduce body odor, and enhance comfort. Cleansing rids the skin of microorganisms that can cause infection and odor. Hair follicles, sebaceous glands, nails, and sweat glands are accessory organs of the skin that function to generate hair. Hair follicles go into a resting cycle and hair may fall out. Usually the hair follicle will begin to grow again and produce a new hair stalk. If left unwashed, hair becomes oily as a result of these secretions. Nails arise from the epidermis and are composed of hard epithelial tissue. Nails serve to protect the fingers and toes. Unlike skin, nails do not slough off and must be cut. Nails are normally smooth and pink and protect the ends of the fingers and toes. The outer layer of the mucous membranes is composed of epithelial cells. We know that from our anatomy and pathophysiology. Just take a look at this listing here and know where these different areas are. Saliva helps to bring the chemical digestion of food and keeps the oral cavity moist. So if you have someone who has MPO, who has kind of some sticky looking gums because they don't get a lot of moisture, you might want to see if you can provide pink swabs with some ice water, and that will really help them be able to produce a little bit of saliva and keep their mucous membranes moist. If they have a disease process that is not allowing them to make saliva, there is an artificial saliva that is available, and that might be something you need to discuss with the physician to provide for them if they can have that, if there is no swallowing difficulties. Many alterations of the skin and mucous membranes affect the nurse's decisions relating to the hygiene care of the patient. Many hospitalized patients have openings in the layers of skin caused by either incisions, surgical sites, wounds, or even ulcers. Damage to the peripheral nerves occurs for a variety of different reasons. It can be from a compression fracture, it can be from the incision site, it can be from just diabetic condition, which causes neuropathy in the feet. Patients may experience alopecia, which is a result of hereditary factors, certain illnesses, or even the effects of some drugs. This condition affects the patient's self-esteem. This is where they lose every bit of hair. They don't have eyebrows, they don't have eyelashes, they have no hair on their legs, under their arms, or on their head or chest or anywhere. It really does affect them a lot in their self-esteem, and so it's important to be able to be aware of that and know that before you maybe bring it up with the patient, or walk in the room and be surprised by it. Again, here is the education on alopecia. Chemotherapy is one treatment that also causes alopecia, but it's more because of the medication factor on the body than it is anything else. There are actual hereditary conditions that cause this too, so be aware of that. All right, my favorite topic in the whole freaking world. Ugh, really, I don't like these at all. A contagious scalp infection, or pedilocus, or better known as head lice. Oh, it just makes me crawl. This disorder is more commonly known with little kids because they share their coats, and the collar of the coat rides up on the hairline, and that's where the eggs are deposited by the adult head lice. And then they hatch and they develop into these wonderful bugs that climb on the headline or the hairline of your head. Transmission occurs through contact with an infested person's items, either combs, hats, linens, coats, scarves, anything like that little children like to share because, well, theirs is better than somebody else's. Some of the symptoms could be itching and redness of the scalp. If the condition is untreated, it can turn into a bacterial infection. So you want to be assessing your school-age children frequently, please, because they're out there. Once they're in your family, everyone needs to be treated, and all the linens need to be treated, and yeah, okay, I don't like it. And I worked pediatrics, and I had a family of 6 little kids that came in, and I'll tell this story hopefully in class if I remember to do so, but yeah, no, it kind of makes me crawl. Let's move on. Fungal, bacterial, and viral infections of the fingernails and toenails occur that cause discoloration and thickening of the nails. You're going to see this in clinical. You're going to see people's toenails that are very yellow and split and callousy looking, and it's not a real pretty picture. And so sometimes podiatrists need to be called in to help take care of this because it's a concern for their feet, and that needs to be treated. Some patients have decreased ability to heal because of poor circulation, so their toes are not going to look as great as what they should be. They might not be real pink. Any cut in the skin can lead to an ulcer in these patients, especially diabetic patients. And like I said, you might need to get a podiatrist to come in and consult on these situations. It's important to be able to report these to the primary doctor if they have not already identified these. Alterations in the health of the oral cavity can affect the patient's ability to chew or overall health. Sores anywhere in the mouth, or gingivitis, which is inflammation of the gums, or any broken or missing teeth, also create a problem with chewing. Therefore, it limits their ability to get adequate nutrition. Certain medications cause the mouth to be really dry, which also is very uncomfortable for the patient, so it needs to be addressed. Halitosis, which is the unpleasant breath odor that some of us have, and some of us don't. Some are very lucky and don't ever have to experience that. That is one of the things that, again, also is very not disturbing to me, but I'm constantly trying to be aware of it because I eat a lot of garlic and I'm afraid that I have this green cloud coming out. Anyway, I'm a visual person. I see green things. What can I say? Some other people that have medical conditions such as diabetes, diabetic ketoacidosis, that has a very fruity smell to their breath if it is in full-blown ketoacidosis. So that's a unique thing to experience. So if you've never smelt that and you have an opportunity to be in a room with someone in your clinical setting that is going through that process, please try to make a mental note that that's something you want to observe so that you can get that scent and know what we're talking about when we say it. Many hospitalized patients have alterations in self-care abilities resulting from their illness, whether it's surgery or immobility or maybe mental status changes. So most of this care will be done by you. Assessing the patient's level of ability to perform the skills, such as self-bathing, will help you also plan their care and provide assistance wherever needed. Patient-centered care requires that the nurse understand how diverse cultural, ethnic, and social backgrounds function as a source of a patient, family, and community values. The nurse provides hygienic care with sensitivity and respect for the diversity of human experience and supports care for individuals and groups whose values differ from the nurses. The female urethra is shorter than the male urethra and is closer to proximity to the anus. So always remember when you're cleaning that area that you go front to back, top to bottom. So you always go front to back. So please remember that. It's very important. We don't want to have any kind of cross-contamination or problems just because we did a bed bath a different way. In Hispanic and Arab cultures, male nurses may be prohibited from performing perineal care or examining private areas of female patients' bodies. So make sure that you are aware of these things and provide one of your coworkers to come in and do this for you, or vice versa. We try to be very respectful of that, and hopefully we provide the best care we can for our patients depending on their needs and wants. North American and many other cultures consider it common to shower or bathe daily. In other cultures, bathing weekly is the norm. Beard in certain religions or cultures indicates that the man is married, and so offering to shave it off might be a problem. Women of some cultures shave their armpits and legs. In other regions of the world, they do not. So if you have a woman that decides that she does not want that shaved, her choice. Persons of African descent tend to have hair that is drier and does not require washing as often. They don't have as much oil or secretions as maybe someone else might. And sometimes obesity creates a unique concern for the nurse as she's providing the hygiene care. You want to make sure that you're lifting the layers and the rolls of fat to get between, say, in the creases of the legs and underneath the breast folds and between the abdomen layers, because you want to make sure that there's no chafing or any kind of skin breakdown. Those areas are usually warm and moist, and where warm and moist are combined, you get bacteria and a fungus infection. So you want to make sure those folds are dry and protected and lotioned and looked at during the bathing process. If necessary, using a mechanical lift to be able to lift your patient up and assess their back and change their bed is also required. During the assessment portion of it, this is part of what you're going to do also. Please gather both subjective and objective data. Even though you're standing there, doing the care for the patient or assisting the patient in their care, listen to what they're telling you and remember it and write it down. It's part of the subjective and objective care that you're providing for them. Self-care focus. Again, these are just some of the questions that you can ask your patient to see how they would prefer their self-care. We have ways of being able to let people who can shower protect their IV sites, and we have plastic wraps for that so they can go in and take their own shower as long as their surgical site is already protected and they have no other tubes or drains that need to be protected at that time. It's okay by the doctor for them to shower. We have ways of protecting all of those different things. So the independence of the patient is always the first thing we look at. We provide them with as much independence as we can with this, but if they can't reach their feet or legs while they're in the shower and they would like you to come do that, then that's your job. That's part of what you do. And it's okay for them, and you don't rush them. Let them enjoy it. Don't let them get worked up over it. If they become short of breath during their bath, let them take a break. It's okay. If they can't raise their arms up to wash their hair or comb their hair, help them out with that. Just simple things. All right, as we're doing the assessment of their skin, you want to make sure that you're documenting everything that you find also when it gets time to go back to your chart and you're doing the assessment to put in that you have done the bed bath and provided the care for the patient for the day. Make sure that you review that Braden scale that's in all the nurse's notes and documents to show that there is no additional skin breakdown, that it's appropriate, there's no pressure points, all of that. So we'll go over those a little bit more in clinical settings because each facility is different, but those are the things you're going to look for, and you're going to address those things in your charting. While gathering the health history, you're going to observe the patient's hair for cleanliness and grooming. This is when they first come in. While assessing the patient's peripheral vascular status, you're going to observe the condition of their fingernails and toenails. You're going to take just a look at that, inspect the oral mucus and teeth, and as part of your complete head to toe. And your way you're going to do that is you're just going to say, hey, could you just open your mouth for me? I just want you to kind of look at your tongue, look at the back of your throat, and can you just stick your tongue out at me? And it's about the only time you're ever going to be able to do that, but go ahead, stick your tongue out at me. Notice if you see any redness in the gums or any teeth missing or cracks or breaks in the teeth at all. Ask them if they have dentures or partials or any of that kind of stuff. Those are just some of the questions that we can always ask our patients, and it should not be something that would be embarrassing or awkward. The patient's self-care ability relating to hygiene impacts your nursing care plan. If they can't take care of themselves and that needs to be something that we address, then that becomes part of the nursing care plan. Patient self-care abilities are assessed during all time in the hospital. If they are not able to do their daily living activities, their ADLs, which is your up to the bathroom and able to wipe yourself, mouth care, grooming, dressing, eating, all of those things that we do every single day, then we need to start providing ways for them to be able to achieve that, whether it be support at home, have home health come in, or if they're going to need to go to a facility until they are able to do those daily activities. Very huge things that we kind of take for granted, really. The presence of skin, scalp, or oral infections may indicate poor hygiene overall. Patient education may be needed to change the patient's view of the importance of hygiene and its relation to health. Now, when I was in high school, we had a foreign exchange student who was from Egypt, and she lived here with us for a while, and she did not bathe except for once a month because in their culture, that was just a treat to be able to bathe. And she came from a pretty well-to-do family in Egypt. So when she came to live with my single mom and me, because my father had passed away, and so it was just my mom and myself and my brother, she was not real pleased with the fact that we didn't have a lot of money. And she didn't understand why every day I would shower before I would go to school, and she just thought that that was a waste. I couldn't understand why she kept pouring perfume on herself because that to me was just disgusting. So there's a lot of differences in a lot of different cultures, and so we need to be respectful of those things. I just bring that up because it just kind of dawned on me there for a minute. All right. Examples of your nursing diagnoses would be hygiene self-care deficit because maybe they have inability to do the self-care. Readiness for self-care, readiness for enhanced self-care, as evidenced by their desire to do their own independent care, they want to do their own care, or ineffective health maintenance related to impaired ability to understand as a result of cognitive changes. So maybe they've had a stroke and now they don't understand that why they can't lift their hand to their mouth, or why they can't do the things that they used to be able to do. So those are some of the diagnoses that you could choose for someone in this area. Again, looking at NANDA, during the planning stage of the nursing process, the nurse prioritizes identified hygiene-related nursing diagnoses based on the patient needs and identified risks. Nursing care plans are developed for each of the diagnoses, considering the patient's self-care abilities, available resources, and family involvement. Setting realistic goals helps the nurse develop a plan of care that will enable the patient to meet the goals. These goals must take into consideration the patient's self-care abilities, family involvement, living situation, extent of hospital stay, and available resources. Each identified nursing diagnosis must have goal statements that are intended to address a specific problem. Examples of the goals or outcome statements could be: patient will accept assistance, my mouth is not working, with hygiene within 24 hours. Patient will begin to perform 50% of her ADLs within 24 hours, or patient will remain free of odor during hospitalization. I always love that. It's like, oh, that's kind of rude, but you get the drift. Okay, so collaboration and delegation, of course. You always want to be able to involve as many people as possible with any of your care that you're doing, just so that it's not a constant in and out of the patient's room with various different people. However, hygiene is one of those situations that is a very private situation. So it's not like you would really want to have physical therapy in there along with you as you're doing the bed hygiene. But if you see while you're doing this with the patient that there's certain muscle strengths or maybe some areas of weakness that you could point out to the therapist, that maybe they could give the patient some range of motion activities or exercises that they could do to increase that, then that's what we mean by collaboration and delegation. Implementation and evaluation. Of course, evaluation starts at the minute that you start your planning and starts with everything that you do, and you are going to be evaluating as you do your interventions, because as you provide a certain type of intervention for the patient to use to accomplish the goal, you're going to evaluate whether or not it was successful or not. And all of that has to do with how you communicate with your patient and how they're able to achieve the goals you two have set. Again, here's the ethical, legal, and professional practice information. It is our responsibility to provide for our patients, to provide them with the best care that we possibly can, to be as kind and professional, and provide them with dignity and let them feel that they are respected in every aspect, even if maybe we don't agree with the way they've taken care of their bodies. That is not ours to say, and so we need to be respectful and be patient and kind and let our patients feel that from us when we are in the room with them. Interventions. So this is where in our nursing care plan that we provide the different types of interventions that we're going to give these family members or even these patients, such as setting them up with their own supplies to do their own care, providing them with support where needed, helping them with proper technique or proper equipment, whatever they might need, whatever the situation might warrant for them. Always involving the family with this so that they are aware of what is being planned for this patient and what the patient can accomplish and what they can't accomplish. Especially if this patient's going to be going home with family and family is going to be caring for them. It's very important that as a nurse, we are prioritizing the fact that this family is going to be taking care of this patient and that they need as many resources as they can when they get home to be able to provide the best and the safest care for that patient, just like you are doing in the hospital. Home care considerations with self-care deficits. This is so you need to make sure, like for instance, we talked about maybe the bathrooms being adjusted with bars in there, slip-resistant tubbing, all that kind of stuff could maybe be done prior to the patient being home or being taken home. that's all stuff that would need to be talked to with the family, and social workers will be involved with that to help out if the patient is going home. Okay, patient-centered care, of course, it's up to them, and we have them try to be as much involved in this as possible. But there are going to be some patients that you do run into that will say, no, I don't need a bath. No, I don't need to. No. But you need to somehow find a way to help them understand the importance of having that bath, or having that, at least washing their face and teeth and personal area at least once during the day. And even if that's just only just before bedtime, that's fine. Whatever works for them, but it needs to happen. During this time, you're also providing a lot of emotional support for this person. You're helping them understand things that maybe they don't understand from the surgery, or just the environment they're in at this moment in time. Avoid massaging the reddened areas. If you find a patient that's been laying on their back for several hours and you roll them over and say they're very frail and they have a very red coccyx area, which is their tailbone area, you don't want to rub that area. You just want to move them off of that area and let that area kind of rest and replenish itself and not have any more pressure on it. We'll talk about that a little bit later on also, but it's just really important that you recognize those reddened areas and document them in your chart, especially during the time that you're doing this care, because you are being so diligent in focusing on the skin, and it's important that you identify where those spots are and note to see if they are reddened or not. I'm going to just interject a little story here right now. My sister just had surgery in Seattle area, Everett area actually, and she had a shoulder replacement done. She just shared with me last night that she was really disappointed in the nursing because she's used to having me be there, and I'm kind of over the top, make sure everybody's happy and good, and me. And this time she had a nurse that came in and kind of just said, okay, this is what we're going to do, and then left all the clothes right there and didn't help my sister, just let my sister kind of flounder on her own. Asked my sister if she was feeling like she was going to get sick to her stomach, and my sister responded yes, she was. And the question was, well, are you going to do it now, or are you going to wait until I can come back with a basin? We don't ask a patient that. They don't know when they're going to puke. They're going to puke when they puke. And I just was like, she did what? She then disappeared for a little bit. When she came back, my sister had already vomited all over her bed, all over her nice clean gown that she had struggled to put on herself. Just was not a good representation of our profession, let's put it that way. She said that when she walked back in and saw that she had vomited on everything, she put the 2 basins that she had in her hands down on the counter and walked out. Now, I don't really know if my sister was just so drugged that she doesn't really remember everything, which could very well be, whatever. She said then 2 other nurses came in and were like her angels. They were very gentle, very kind, took care of her, did what she needed to have done, cleaned her bed, cleaned her gown, cleaned her up, let her feel better. But then she had to have the other nurse back after the end of the shift, or towards the end of the shift, for the rest of the shift. And she just felt like there was this bridge that had been kind of laid there, kind of this barrier between the 2 of them. I guess from that little story, I just want to tell you, patients don't have control over the meds that they're given as far as in anesthesia. They don't have control over how that makes you feel when you're coming out of that medicine. And it takes a while for every body to have that be cleared. So you're not always clear from anesthesia the minute they send you out of recovery room. And some bodies aren't used to that med, and so they react differently. And it takes a while. So I guess what I'm saying is just be respectful of your patients. That's why I always say be present. When you're right there beside them, be present. Don't just be there. Don't just, fake like you're listening. Really, really listen to what they're saying. Be there. Let them know you're there. And you're going to do whatever you need to do. and you're going to bring everything with you at one time so you're not running in and out, in and out, and you're going to focus on them. And I'll tell you, those experiences are going to be so much better for you and so much better for your patients that you're never going to have anyone say, I didn't like that one nurse because they couldn't care for me right. You're never going to have that said about you. I guarantee it. All right, moving on. Bathing and skin care are essential components of patient care. The amount of assistance patients need depends on the self-care abilities, and you will assess those. Hygiene teaching can be incorporated throughout the care. So as you're bathing someone, you can just say, hey, if you put lotion on just right after your bath, before you dry your skin, it helps to absorb into the skin a little bit more, and it makes it a little bit better. And if you don't rub your skin, you just pat it dry, it doesn't dry your skin out as much. So those little tidbits that some people don't ever know those things or have never been told those things. After the bath, the nurse documents the type of care performed, date and time, skin assessment, patient's current position. You always want to move them to a different position so they're not putting pressure on the same spots, ability to assist, and how the patient tolerated the whole entire thing. All right. So the nurse or unlicensed personnel, no, we don't have those, remember. So the nurse or the CNA washes the patient and performs passive range of motion while you're doing the bed bath. It's the most appropriate time to be doing this, especially with those patients who are bedridden and are totally and completely dependent on others. So when you're washing their arm, you lift it straight up and let the shoulder move with it and very gently move it over their head and bring it back down, and you're just working those different ranges of motion so that they don't freeze up, the joints don't freeze up. Patients are able to move their elbows, they can move their hands. You're washing under their arms, so you're moving their elbow. All of those different things. You can use washcloths, you can use soap. I usually take the Baby Johnson shampoo that they have at most facilities. I use that as the soap for the body. I know they have a no rinse soap that usually dries most elderly people out, but there is that's available. They have the new towelettes that are moistened and you don't have to rinse people off with them, so there's that. But really, the Johnson's baby shampoo doesn't really need to be rinsed off either. It smells good, so there's an option for you. Plus, I like babies, so there you go. Anyway, use whatever your facility has, but those are some suggestions for you. I also put lotion in the warm basin of water so that as I'm doing the bath, that lotion is warming up. And that way, when I'm putting lotion on their skin, it's not a cold shock to them. Okay, so purpose of doing a bath, here it is, and I'm not going to go through it with you. And here's the collaboration delegation. And it continues on and on. Now we're going to talk about partial bed baths and sink bath, where if the patient wants to stand at the sink and just use the water as it runs from the sink, that's fine. If they want to go to a shower, that's fine. We have that available also. Just remember, we need to always be aware of what they can do, what they can tolerate, and that we are not going to be just setting them up and leaving them and letting them go. All right, chair showers. Now, this is a nursing home type thing, and I'm going to share a little story with you on this. My poor mother had a stroke, and you'll know more about that later on. But while she was in the nursing home, they would come and they would take her and strip her down, put her in a shower chair, put a blanket around the patients, and I'm saying her because I'm sure this is what they did with her also, because this is what I saw them do with other patients, and take from her room and take her down the main hallway where everyone was at and into the shower room, which is a huge open shower room, and shower her down in the chair. Now, I know that they have to do things quickly. I know they have a lot of people. I know that most people that work in nursing homes have the patience of Job, and I love them and think they're great because I could not do that. But my mother was mortified with that whole entire experience, because even though she had a stroke and wasn't able to totally walk on her own, her mind was still completely there. And she was this most independent, proud woman I have ever met, and I don't blame her. I would not have liked that either. sometimes we have to think about that for our patients, and we have to realize that maybe we need to alter our plans a bit on what would be most appropriate for them. Anyway, just a thought. Okay, Safe Practice Act. Of course, you want to make sure that the water is appropriate, the temperature for them, especially if they're going into the shower. It needs to be the right temp so that they don't burn themselves. That's usually not a problem. It's not usually set that high. Make sure that someone is close by, so in case you hear something in the you hear them slip or they yell out for someone's close enough by to be able to rush in and help. Want to make sure that you use a very soft voice, reassuring, especially for your patients with dementia. If you start yelling at them and arguing with them, they just become more belligerent. So if you try just to use the kind of reverse psychology with them, sometimes you can get through the process a little better. All right. Perinatal care is particularly important for patients who are dependent or incontinent and those who have a urinary catheter, because we need to make sure that we're cleaning around that so that the microorganisms don't climb, don't get up into the urethra and climb back in and get infected. I know that sounds gross, but that's what happens. Always wear gloves when you are providing the perinatal care, and you don't want to be exposed to any of the body fluids, so you always want to be wearing gloves. Want to make sure that you document the care that was given, what date and time, any skin-related issues, how the patient tolerated it, and if you noticed any changes in the skin or any drainage or discharge. For men, when you are doing personal care for them, if they're uncomfortable with a female helping them, please find a male nurse. That's one of the nice things about one of the many nice things about having guys in the nursing programs and out in the nursing floors. For the longest time, I worked with just straight guys on nights because I don't know why. I loved it. I love working with guys because there's no drama. There's no girl games. There's none of the girl stuff. And it's pretty nice, actually. But I do love how we have the ability now to help our patients have that option. If they are uncomfortable with a female washing them or caring for them in that regard, or placing a catheter in them in this regard, then we have that option of having to go and get one of our guys and say, hey, could you, go get this done for me, or, could you help out because this patient would prefer this. That's one of the really nice things, is we are able to provide for our patients that opportunity. The same goes for females. If they prefer a female to do the care, then that's okay. Same thing. Same thing applies for both. All right, now it just goes through the skills check off on this, so please just go through those slides and I'll catch up with you in a minute. Foot and hand care. It's important that we provide foot and hand care while the patients are in our care. We need to make sure that we're assessing their feet, see how they do with feeling, see if they are sensing the touch down in their feet area, especially if they are diabetic. We need to make sure we're documenting those findings. We need to make sure we're inspecting the toenails, making sure that they're not rigid or ragged and rough and possibly could cut their feet. Those are all things that we need to look at. Again, like I said, if we need to contact a podiatrist and get them to be looked at for further care of those. Again, now the next couple of slides are going to be the skills, so go through those and I'll catch you on the next one. Massage. So there's some different types of massage. It provides relaxation and comfort. It increases circulation. It promotes sleep. Areas of the body that can be massaged are the arms, the hands, the legs, the feet, the neck, and the back. A back massage may be given as part of a complete bed bath at any time of the day, and a variety of techniques are used during the back massage. The technique stimulates the skin but should not be used over the kidney area. So the whole purpose of this is just to release the tension in the muscles. You don't need to do it real firm or hard or deep. You just need to be soft touch. And usually, like I said, I use just some baby lotion or just lotion that they have. Doesn't have a lot of smell to, anything that isn't real perfumey, because that usually sends most people right off the deep end. So you just use gentle touch, small circles, and don't just, don't do a lot of pushing or trying to work out knots or anything like that. That's not really the intent of our massages in the hospital. They're more for relaxation. All right, so skills, if you're going to give one, go through these slides. We're going to talk now about hair care. So shampooing, they have, sorry, my computer did something weird. Hang on just a second. There we go. Thank you. Sorry for that. They have shampoo caps. The caps have shampoo that is in the cap itself. You put it in the microwave for about 15 seconds to 20 seconds. It warms it up, so it feels like it's a nice warm sensation on their head. You put the shower cap on, and then you kind of just rub it over their hair, and it's like a shower, or it's like you're scrubbing your head when you have shampoo on your hand. That's what I'm trying to say. It's like a no rinse soap, so when it comes out, all you have to do is take a towel and dry the hair off, and you're good to go. Some of the other things that we can talk about is nit removal. That is when they have head lice. Oh, that perfect thing again. You can get the chemical nit removal and use that, or you can use mayonnaise and a shower cap. You put mayonnaise all along the hairline of the patient, put a shower cap on, leave it on for 24 hours, take it off, and it has suffocated the head lice and also moisturized the hair while you're all at it. So it's a 2-for-1 special. It's just depending on facility as to what you will use. If you do use the chemical version of the head lice removal, then you will need to comb the head lice out. You'll need to do that for the mayonnaise as well, but the chemical one usually is a little bit more aggressive, and the pharmacy will have to bring that for you. Always make sure you document what you did, what you used, excuse me, and how the patient tolerated it. And now the slides for hair care, moving through them. Let's go back to oral care, and we're going to talk about that a little bit. We did a little bit earlier about oral care. Make sure when you are brushing teeth or anything like that, that you provide them with the opportunity to do as much care for themselves as they can. If they have dentures or partials and they are not able to get up and go to the sink and wash them, you could set them up with a basin and let them wash them right there in their bed, whatever they want to do, or you can brush them for them. I don't use toothbrushes on dentures because they usually scratch the surface, so I will use a gloved finger and I will clean them that way. I always let the patients watch what I'm doing so that they can see that I'm, how I'm doing it. I usually do it at the sink and with my back halfway turned so that they can see what I'm doing. You will always wear gloves whenever you do this with the patient. They don't have to wear gloves when they're washing their own dentures. Patients can do their own oral care. Just make sure that you document that they were able to do it and that you didn't notice any bleeding, or they didn't complain of any tenderness or any sores or anything during the time that they were cleaning their oral care or doing their oral care. All right, so we're just going to skip through all those others and go on to the skills of the oral care and skip through those. I hope you will spend some time looking at the slides that we're kind of briefly going through. We're not even going through them, we're just skipping them. We're going to talk a little bit now about eye care. if I can find my paper. My, there's a lot of oral. All right, here we go. Eye care is part of your bath routine. In the patients whose eyes do not totally close at night, you need to maybe either provide eye patches for them, or maybe they need artificial tears to be placed in their eyes to prevent corneal drying. If they get too dry, they will scratch, then it causes infection in the eye and it causes more problems. So if you are working nights and you see that your patient does not close their eyes all the way when they are sleeping, you might suggest that to the day shift to have them get some artificial tears for that patient, and then also institute that for them at home. Patients who need glasses or contact lenses should be encouraged to use them while they are in the facility, so that they can be able to see and do and function as if they were at home. Have the glasses handy and nearby at all times for them. If they do wear contacts, those contacts will be taken out prior to a surgery. Make sure they have a lens holder so that they can have those contacts when they get out of surgery. And also make sure that the container that is holding those contacts and the container that holds their glasses has their name on them, so that we don't lose anything. That's one of the other things that's always a concern, is losing people's glasses or contacts or dentures. If the patient is able to remove their contacts for themselves, they may be wearing disposable ones, so they might just want to get rid of them, or reusable ones, or ones that they might actually wear all the time 24/7. If they do, when you're looking at their pupils, make sure you're aware of that, because that might change the way the pupils react. Make sure you understand that before you do your assessment, so it doesn't throw you off. Other than that, patients are pretty much on their own for dealing with the contact lenses themselves. If a patient is in trouble as far as the contact lens gets stuck in their eye and they can't get it out, or anything like that, then yes, you are able to provide care and help them with that. Always wear gloves. That's all I'm going to say. Okay, make sure that you document that the patient is wearing contacts, or has any kind of eye troubles, complains of swelling or burning or irritation, or has drainage in their eyes. Any of those things need to be reported, especially if there are changes in the patient or changes that they report. Evidence-based practice, just make sure that you look this slide over. I had a girlfriend that had a fake eye, and I used to say to her, "Hey, would you keep an eye on my purse?" And she'd literally pop the eye out and put it on her purse. It used to make me so sick. People do have fake eyes. They look really non-fake right now. They've really come a long way from the old glass eyes that used to be out there. And sometimes it's pretty hard to tell if they have a fake eye. So sometimes that's a question we can ask, and especially if we're not really sure. It's not a bad thing to ask the patient, "So how come your one eye looks this way and one eye looks that way?" Or, "Did you ever know that did that?" And sometimes they'll just flat tell you. So it's okay to ask the questions. If the patient requires assistance with the fake eye, sometimes all you have to do is just hold the lower lid down, and they can work the eye in without a problem. Sometimes we're going to be required to help with nasal suctioning, especially if it's with someone who has a change of mental status. So it's important to make sure that we use the proper equipment and are careful, very careful with the nose, because the blood vessels are very close to the surface and are easily irritated, and we certainly don't want to cause nosebleeds for our patients. So especially when we are taking out NG tubes or anything like that, we want to make sure that we're providing the utmost care for them and not having it be traumatizing for them. Ear care. We usually don't do a lot of ear care. In the ER, we do a lot of wax removal. It's amazing how people can go for months without realizing that they've got this huge buildup of wax in their ear. But that is something that can be done and can be done easily. So if you do have a patient that can't hear and they have a buildup of wax and you're told to remove the wax, well, we'll get it done. Make sure that when you are doing their bed bath, you just wash the outer aspect of the ear with the washcloth. You don't have to go deep inside. We certainly don't use Q-tips inside the ear. You know, the old adage, if it's bigger than or if it's smaller than your elbow, it doesn't go in your ear. So nothing goes in the ear. I want to make sure that if the patient's wearing hearing aids that you're aware of that and you know how to operate them, at least to the point of being able to, you know, be careful with them, and the patients usually take care of their own without a problem. Sometimes they start squawking or you hear a high-pitched sound, and it's because they've got their head on the pillow and they don't realize that it's making that noise, and all it is just interference with the hearing aid. And so all you have to do is just go in and say, hey, your hearing aid's turned up a little too high, so can you turn it down? And they usually adjust that without a problem. So just be aware that hearing aids are sometimes inside the ear that you don't even see. So when you're doing the bed bath, beware of those. You don't want to get a lot of water in there. Okay, so talking about the in the ear cannula, a lot of people are using amplifiers now instead of actual hearing aids, and so they do just fit mildly inside the canal of the ear, and they're really super tiny, and then all you see is just this little, almost a little string coming out with a white end. Very hard to see unless you're really looking for it. So the main thing is just don't put a really wet, soggy washcloth up to the ear without knowing what's in the ear canal. That's asking the patient. Cochlear implants, I've seen a few of those here in the Valley, not a lot. They are the ones that are plastic earpieces that have a tiny microphone that fit within the ear that are also surgically emplaced. So those are things that you can watch for as well. Make sure you document which ear it was, document any drainage you see, if there's devices present, if so, what type, if the patient took care of them, if the patient has any complaints or has any changes in hearing. Shaving a patient, please look at this slide. We usually don't use a lot of razors. We have electric ones in the ER to use for really bad or really hairy chests when we need to do EKGs, but they really don't use a lot of razors for shaving anymore due to the fact that it has led to more infection with cuts than anything. So if the patient does want to shave, that's fine. Hopefully they've brought their own equipment with them. If not, we do have the disposable razors, and we can help them with that without a problem. Safety practice alert. If the patient is on blood thinners, please do not let them use the double-bladed throwaway razors. Please let them use an electric razor, because the double blade will cut them more severe than an electric razor will. So that's just something to be aware of, and might even be on a test. Oh, did I say that? Oh. Beards or mustaches should not be shaved off without the consent of the patient or the family. Yeah, don't pull the old, my buddy's drunk, let's shave one eyebrow off type thing. Don't do it unless the patient says it's okay. And if the patient says it's okay, wait till you have a family member around and ask them. I had a patient once say, yeah, it's okay, let's go ahead and just shave this mustache off. I've wanted to do that for a long time. And I said, nah, let's wait till your wife gets here, I just feel better if we just would wait. So the wife came in, and the husband said, I'm going to shave this mustache off. And she said, over my dead body. Yeah, really glad I didn't shave him. All right. So here is just the skills for that. Please look at these two slides for shaving a male patient. I guess this also could be a female patient if she's growing hair on her face. I just pluck them out. Don't worry about it. Bed making. This is something I'm not really going to spend a lot of time on. You guys know the importance of bed making. You know what you need to have. You know that you need the fitted sheet, the draw sheet, or the lift sheet. You know that you need to have a top sheet and the blanket or bed sheet, whatever you want to call it, bedspread, whatever you want to call it, on top. I always want to make sure that I have all of that available in the room so that I'm not having to run out and get it and leave my patient at all while they're doing either their own care or stranded while I have to run go do something. You can always load all of that up and put it in the room and have it there ready and be able to do all of that in the bed bath and everything all in a short amount of time without having to leave the room, and that is so important. Linens don't always fit real snug and nicely on the beds, and so if you have a patient that moves a lot, they're going to have wrinkles like crazy, and the wrinkles end up getting right underneath you in bed, and then you sweat and you're uncomfortable and the gown doesn't fit, and it feels yucky. So having a nice clean bed is always such a wonderful feeling, especially if you're in a hospital for any long period of time. That's probably one of the nicest things you can do for any patient. Most patients don't like to sit in any of their secretions, whether it be vomit, pee, or poop. Even if they mentally are not there, trust me, they don't like sitting in it. So let's just be really proactive in getting our patients out of that situation and in clean situations so that they are comfortable while we are caring for them in our facilities. Okay, you're going to go through a couple of slides on the bed making. Now we're going to talk about evaluation, because now we're done with all our skills, and of course we've evaluated all the way through. We've adapted our care as we've been evaluating to make sure that we're reaching the goals that we've addressed with our patient, that we've agreed upon with our patients, that this is the kind of stuff we want to do with them. We want to make sure that our patients are aware of the care we're giving, agree with the care we're giving, striving for the same goal that we're trying to get them to achieve, and be able to have a good stay while they're with us. Also, in all of that, we're trying to make sure that our patients are cared for in the most convenient or the most appropriate manner, and being able to provide them with the utmost confident care that we can. So, outcome criteria is always per patient. The same is not going to be for one patient as it is for the other. Each one is different, every patient's different, and you have to remember that they're not the same cookie cutter cutout. All right, guys, we'll see you in class. I hope you've enjoyed these. Sorry for the many multiple mistakes. My mouth just doesn't work sometimes. Bye.